So right now we're going to be going over the lumbar scan. We're going to be covering a few different topics such as posture analysis, active and passive range of motion assessment, myotome and dermal testing, as well as special tests. So this is going to be your special helper and demonstrator for today. Her name is Jolene. She is a fantastic subject and she is allowing us to work on her today. So first we're going to start with the posture analysis. You're going to have the patient stand in front of you. You can have them do a couple marches up and down and then stop their feet. So here you're going to look at the height of the ASIS, see if they're equal, see if one is higher than the other. You're going to look at the trunk, and obviously I'm facing forward, but you're going to want to look behind them, look at their spine. You want to see if there's a lateral shift. You can look at them from the side, see if there's kyphosis or lordosis. You can look at the feet, check if there's some internal rotation, external rotation, pronation, or supination there. So next is the active range of motion assessment. This is also standing. First, you want to do some side bending, have the patient put their hands by their side and have them bend all the way down as far as they can go comfortably to one side. You're going to want to look at them from behind, see if there's a smooth curve of the spine, looking at the spinous processes. You're going to also want to compare the left side to the right side, see if there's a difference. If there is a difference, you can use a measuring tape and measure from the tip of their finger all the way down to the floor in centimeters and document the difference. You're going to also want to check their flexion range of motion, so you can have them put their hands on the front of their thighs and slowly work their way down towards the floor as far as they can go. You're gonna also want to look at them from behind. You can check their spinous processes to see if those are lined up. You can see if there's a scoliosis or deviations of those processes. Last thing standing you want to check is the S1, S2 myotome. This is going to be testing the gastroc. You're going to have the patient put a hand on the table, but make sure they're not putting too much weight for it. This is just through stabilization. So you're going to do 15 unilateral heel raises on each side, and you're just looking for fatigability of that muscle. So next we're going to move to sitting. First thing we're going to do is an active range of motion assessment for trunk rotation. You're going to have the patient sit on the corner of the table with their knees kind of locked in the sides to stabilize their lower half, and you're going to have them cross their arms across their chest, and then they're just going to rotate to the left and to the right. This is looking at thoracic range of motion, and you're going to want to assess them from the front and from the back and just make sure that both sides are equal. Next, you can do reflex testing. Here we're going to do the patellar reflex, which is testing L3 and L4. You're going to want to look for if there's hypo or hyperreflexia, and you're going to want to compare bilaterally. I think she has a upper motor neuron lesion. I'm sorry. Next, you can do this one sitting as well, but the skeleton is so hard to manage. So we are doing it supine. But here we're going to be testing the gastroc tendon reflex for S1 and S2. You're going to want to apply the foot, push it into dorsiflexion while you're doing this test to apply tension there. And you're going to strike the back of the heel. You can palpate the calcaneus and just go slightly above it so that you're on the tendon. And just strike it firmly with the mallet, and you're going to want to feel if the patient plantar flexes into your hand. Then that is a good sign the reflex is normal. Next, we're going to be doing the straight leg raise. This stresses the dura and can indicate if there's neural involvement if the patient has a positive test. You're going to want to begin and push the patient's foot into dorsiflexion and then slowly extend the knee. And then once that knee is in full extension, you're going to have the patient tuck their chin into their chest. However, if you perform the straight leg raise and it's inconclusive, you can go and do a further progression, and this is going to be the slump test. So it's the same thing, arms across chest, tuck chin, slump over their hands, lean forward just a little bit, and then you're going to put the foot into dorsiflexion, extend the knee, and see if those symptoms come on. If they do, have them get out of the slump position, extend their neck back up to neutral, and see if that relieves the pain. If this does, then this is also a positive test. So next we're going to do myotomes. So first is just going to be for the quads. It's going to be L3. You're going to want to be trying to push the patient's heel down back towards the table while they kick up into your hand. And then you're going to also test the hamstrings. You're going to just do the opposite of this motion. So you're going to try to pull the patient's leg out while they try to curl and flex their leg in. This is going to be testing L5 and S1. Next, we can test the hip flexors. You can do this sitting or supine. I just chose to do it supine because it's easier at the moment. But this is testing L2. You're going to want to bend the patient's knee and hip to a 90 degrees. And then you're going to grasp just above the knee and try to push the patient's leg down into extension and have them resist you. Next is anterior tibialis. This is going to be testing L4. You're going to want to move the patient's foot into dorsiflexion and inversion. Have them hold that there while you try to pull their foot out into eversion. Next, you can test the extensor hallucis longus. This is going to be for L5. You can test these at the same time just to see if the both sides are equal, since it's such a small, easy muscle to test. You're just going to grab on top of the big toe with each finger and try to pull their toes down into flexion. Okay, next you can test the fibularis. This is going to be for L5 and S1. You loosely move the patient's foot into eversion, have them hold that there while you're grasping the lateral aspect of the foot and trying to pull that into inversion. Next, we're going to test the dermatomes. So first you can begin with light touch sensation. You can use a tissue. And you're going to also just test the different dermatomal patterns of the lumbar nerves. Something to keep in mind when you're doing the light touch sensation is to switch sides. Have the patient close their eyes and say yes when they can identify that they've been touched. You're going to want to touch different areas of the feet, do a different pattern, different speed, just so that they don't get a hold of your pattern, and say yes when you haven't done anything yet at all. After you've done the light touch sensation, you can continue with sharp sensation. And you can use this just using the sharper end of a reflex hammer. It's obviously not going to cut them, but it's more sharp than a tissue. You can do the same pattern, same tone, and just have them identify when they feel the sensation. Next is going to be special tests. Here we're going to do a supine straight leg raise. So here it's going to be testing the L4 to S2 nerve roots. You're going to want to have the patient's leg in 30 to 65 degrees of hip flexions, because this is where the maximal motion of the roots is going to occur. You're going to have the ankle in dorsiflexion and then raise the leg into that 30 to 65 degrees. Hold it there and then have the patient tuck their chin in, see if the symptoms come on. If they do, extend the neck back and see if that relieves the symptoms. If it does, this is a positive test. Next is going to be the compression overload test. This is testing the vertebral body, intervertebral disc, and is also going to include the basilar vertebral vein, causing an increase of pressure in the body. So kind of a mouthful there, but it's grabbing the patient below their knees. You're going to want to grab under the feet, kind of add some dorsiflexion with your forearm there. Bring the knees up into the chest, and then with your hand that is under the knees, you're going to want to lift up a little bit so that their glutes slightly raise off the table. You're going to lift that and then hold the position for 10 seconds. This will do that occluding of the vein and will increase pressure in the body. So if there is a pathology present, this will increase their back pain. It'd be a positive test. Okay, next is the sacroiliac stress test. First is going to be the anterior ligament. Here we're going to put our hands in an X pattern and palpate the ASIS, kind of iliac area. And you're going to want to put your thenar eminence on both of those sides. Try to push them both out laterally at the same time, and this is going to gap the anterior SI ligaments. Next one is going to be rotational testing. You're going to take one hand and push up on the ASIS, and with your other hand, you're going to be pushing down. Now, the hand pushing up is testing posterior rotation, and then the hand pushing down is testing anterior rotation. You want to test these one-sided, and then switch your hands and change direction. A positive painful test here can indicate inflammation of the SI joint. Next, we're going to be testing the posterior ligament, and for this one, the patient is going to be side-lying. You're going to place one hand on the iliac crest and apply downwards pressure. This is going to gap and stress the posterior SI ligaments. So next, we're going to be testing for clonus. So here, we're going to apply a sudden dorsiflexion of the patient's ankle, and if 3 or more beats are felt, this is going to be a positive test indicating an upper motor neuron lesion possibly. So first, when you're beginning the test, just kind of loosely move the patient's ankle up and down, so they're not, trying to predict what you're doing. And then when they're not expecting it, just suddenly forcefully push them into dorsiflexion and feel if there's 3 or more beats, any beating of the foot that's pressing into your hand while they're doing plantar flexion. This is an abnormal response. It could indicate an upper motor neuron lesion. Next is the Babinski reflex. Some people argue it's not a reflex, it's a sign. Babinski sign reflex, whatever you want to call it, Babinski. So here you're going to use a hard tip to scrape the patient's foot. You're going to move from the heel, you're going to move laterally and then across the metatarsal heads going medially. If the toes flare out into extension, this is a positive test.
and can indicate an upper motor neuron involvement. So here you're going to want to do it in one fast and hard motion. So next is going to be Hoffman's sign. This is the upper limb equivalent to the Babinski sign. And here you're going to hold the patient's hand in a restful position. You're going to want to grab their proximal phalange and then kind of hit or flick the distal phalange really in a quick motion and see if their thumb or index finger flex. This is going to be a positive sign and can also possibly indicate upper motor neuron involvement. So next is going to be the range of motion scan. We're going to be checking hip flexion first. So you're just going to grab the patient's leg, move it up into flexion, see how far they can go, compare to the other side, and see if there's a difference between the two. So next is going to be internal rotation. You're going to bring the patients up into a 90 degrees of flexion, and you're going to move the leg into internal rotation. You can go the opposite direction, move into external rotation, sweeping the foot. If you see a discrepancy between the two sides, goni it and document it. While we're prone, we're also going to do a myotone testing for the glute. So you're going to have the patient raise their knee up and slightly off the table while you push down, basically over their hamstrings. You're going to push them down into the table, saying, hold this position, don't let me push you down, and you're pushing down into the table. This is going to be the femoral nerve test. This is testing nerve roots L1 to L4. So for this one, you're going to want to put the foot into plantar flexion. You're going to want to flex the knee and then also extend the hip. If during this motion there's pain in the back, during this motion, if there's pain in their back or if they feel anterior thigh pain, that kind of neurological, numbness and tingling starts, that's going to be a positive sign. Next is going to be the torsion test. So for this one, this is testing the neural arch to withstand rotational force while also testing the ligament and discs that are also under that rotational force. To begin the test, you're going to want to find L1, and then you're going to want to grab the patient's side and hook your fingers just under the ASIS so you have something to good and grab onto while you're doing this movement. So you want to apply downwards pressure through the spinous process while you're also lifting that ASIS up off the table and trying to rotate the hip medially. So here you're going to hold this position for 10 seconds, and if the patient experiences unilateral pain, that could indicate a ligament or disc involvement. However, if they experience bilateral pain during this motion, that could possibly indicate a neural arch fracture. Okay, so lastly is going to be the PA spring test. This is testing the ability of the vertebral segment to withstand a quick anterior force. Using the PC form of your hand, you're going to want to palpate the L5 spinous process segment. You're going to want to apply some pressure first to take up the soft tissue slack, and then you're going to perform a quick overpressure with your hands. This can also be performed with the overpressure being held for 10 segments, but a positive sign is if the patient feels a pain or spasm. Oh, good job. You're okay. What's happening here? What is happening here? Hypermobile. Oh, uh-oh. No. I think you have some OA going on there, bud. Sorry to diagnose you with that. Okay. I'm gonna stop the camera.